There are a lot of institutions, maybe not a lot, but some, one in California that are actually looking at the NGS data and maybe sending 5 different NGS tests and proteomics, et cetera, and then
Yeah.
designing these personalized combination therapies based on preclinical data or data from other diseases. And I've always felt a little bit concerned about that approach. I mean, obviously, each patient is an individual. We want to do the most we can, but then I worry a little bit about toxicity. And I don't know what the payers are thinking about. Mostly, this particular institution can get the drugs covered, actually.
Yeah. Well, I would say, first of all, that using NGS testing alone to inform a treatment decision outside a trial, I don't know of any payers that would cover that. My best example of that was in melanoma, when patients had a BRAF V600E mutation. You could use targeted therapy or a BRAF V600E mutation with a MEK mutation, and you could use combination therapy in those patients. But if you use that same drug in patients who have a BRAF V600E mutation in colorectal cancer, actually the outcomes are worse. And so simply extrapolating that patients are going to benefit based on a molecular mutation is not evidence-based. And again, most payers would not cover that knowingly. That doesn't mean you can't get the drug in a compassionate use basis, but payers should be denying that because there's no evidence to support it.
Yeah, it's interesting. I mean, I think the management and sort of utilization and costs and all these issues play a huge role. And sometimes there are studies where there are really, a few patients that have been treated who have breast cancer, and yet the drug gets approved all across the board. And presumably the payers will cover those drugs for patients.
Yeah, again, if it's in the NCCN guideline, it's going to get covered. It's interestingly, though, oftentimes, especially outside the cancer setting, the FDA-approved label is broad, and so we look at the clinical trial population that was used for the FDA approval to identify the patient subsets that are appropriate. Yeah, with the atezolizumab, if you don't have a positive PD-L1 titer, we're not going to approve that drug. And that's in the label, but there are some providers who would want to use that off-label. And in non-small cell lung cancer, providers still want to use nivolumab in first-line non-small cell lung cancer, even though their clinical trials failed. So that doesn't mean that providers can't be compassionate, but they also have to be evidence-based.
Yes, indeed. And, it's a hard thing when you're doing all these peer-to-peers and need to provide all the data, and the patient's there going, I want that drug. Yeah. Anyway, we're always dealing with that. Priyanka, how do you deal with those issues? And do you do NGS in all of your patients too?
So I think, like everybody else, at time of first line, for most patients, I'm doing it. There's clear utilization in those with hormone positive disease. For triple negative, there's those rare activating HER2 mutations or MSI high that you find that you can match them to drugs that are available. Pembrolizumab approval for MSI high across all solid tumors. I think that trial only had 2 breast cancer patients. So it goes back to the point where we get these drugs approved, we don't necessarily know how well they're going to work in our specific tumor types. But beyond that, it is to kind of look for trials, for PI3 kinase inhibitors or AKT inhibitor. And recently we've had some data on high TMB and efficacy of pembrolizumab monotherapy, although that's not FDA approved yet, but that trial did show some reasonable efficacy. So I would consider getting pembrolizumab off-label in that kind of a population with high TMB.
So, and that's a great example, because I think there may be anecdotal evidence to support use in TMB high patients. We as a payer wouldn't cover that because it's not an FDA-approved indication. It's not in the NCCN guidelines. But interestingly, that doesn't prevent you as a prescriber from getting that drug in a compassionate use basis of the patient paying out of pocket. So what do you do in the circumstance where something is used off-label without evidence, and yet the patient responds? I think we've dealt with that several times actually as a payer, because patients do get NGS testing or TMB testing, and they do respond. In that circumstance, we've made a decision as a payer that if a patient is deemed to be a responder, either a partial or complete response, then we are going to pay for the therapy the 3rd month on. You can't say it's experimental investigational if the patient is considered a responder anymore in one experiment.
No, I mean, I think that's a really important distinction that you just made, because
Mhm.
I think we've maybe all of us have run into the situation where we had a patient who was responding, say, to single agent pembrolizumab given on a compassionate use, and the insurance, a year or two into it says we're not paying for the infusions anymore. But we have successfully argued that that doesn't seem to be really reasonable in
Yeah.
that situation.
Well,
So,
our primary reason for denying that coverage is it's considered investigational, experimental, or unproven. And by the time you have a patient who is a responder using RECIST criteria, then it's very hard to argue that in this N of 1 experiment that they're not a responder.
yeah, absolutely. I think we've heard from everybody. Claudine, do you have any final comments about that?
No, I think that we've addressed most of them. I think one of the other things just to bring up that others have alluded to are that we sometimes find mutations in genes in the HRD pathway, and certainly the role of PARP inhibitors is being looked at beyond BRCA1 and BRCA2, and looking at somatic mutations as well. So there are some clues that come up that I think can be very useful in everyday life, although truly more so in directing patients towards clinical trials.
Absolutely. And I think that what Priyanka brought up about these HER2 somatic mutations also really important, since it seems to be more in our ER positive group, where we really haven't been focusing as much on NGS, I think, except for PIK3CA mutations. But now we're going to pick it up.